Now let me explain causes of vitamin B9 and B9 deficiency. Okay, first about vitamin B12. Okay, we can store vitamin B12 for more than 5 years, and we discussed it in previous part. But anyway, one cause of vitamin B12 deficiency is less intake. Okay, and it's not most common cause. Okay, the most common cause of vitamin B12 deficiency is malabsorption. It means we cannot absorb enough of vitamin B12. But in less intake, for example, in vegans are those people that they do not use animal products. For example, Indian people. Okay, so they will suffer vitamin B12 deficiency easily, and most of the time they also don't suffer vitamin B12 deficiency because other products that they use it, these products are enough for uh, amount of vitamin B12 which is needed in our body. But anyway, in malnutrition people, the nutrition is weak. Okay, and also in chronic alcoholism. Chronic alcoholism means that they use alcohol for long periods, because using of alcohol for long period disturbs metabolism of vitamin B9 and vitamin B12. Got it? Plus, breastfeed infants, mothers that they don't have enough vitamin B12 stored in their bodies. Okay, so th- during breastfeed, these infant also will face with vitamin B12 deficiency, because infants only use breast milk. They cannot use other products. Okay, they cannot use, for example, any other thing that they gave vitamin B12 for the baby. Got it? About the malabsorption. This is the most common cause of vitamin B12 deficiency. Okay, for example, a subtype of malabsorption is pernicious anemia. Pernicious anemia is a deadly type of anemia. The problem in pernicious anemia is that we discussed all about metabolism of vitamin B9 and B12 in previous lecture. But anyway, in pernicious anemia, these antibodies are developed against parietal cell of stomach. Okay, for example, this is stomach. Okay, here inside the stomach we have types of cells that they are called parietal cells, and parietal cells produce two important things. First, they produce proton, and proton is essential for the making of HCl or hydrochloric acid. And also these parietal cells produce intrinsic factor. An intrinsic factor is essential for vitamin B12 absorption, that we discussed it in previous lecture. So antibodies against the parietal cell, they will destroy parietal cells, and we will have less HCl, so we cannot digest foods that they contain enough vitamin B12, and also we cannot absorb vitamin B12 due to lack of intrinsic factor. Plus, we will not have enough pepsinogen. Plus, sometimes antibodies are developed directly against intrinsic factor. We discussed that when we take vitamin B12, okay, so this vitamin B12 will be bind to intrinsic factor, and intrinsic factor prevents from degradation. Sorry, intrinsic factor is important for prevention of destruction and degradation of vitamin B12 by trypsin or pancreas enzymes. Got it? So when we develop antibodies against intrinsic factor, okay, so we will have two types of antibodies, type 1 and type 2. Type 1 prevents from binding of intrinsic factor to vitamin B12 in stomach. Okay, and type 2 antibodies prevents from binding of intrinsic factor plus vitamin B12 plus cobalamin. Okay, for example, we have small intestine and ileum. In ileum, we have receptor which is essential. We discussed all of them in previous lecture, which is essential for binding to binding to cobalamin or vitamin B12. Okay, so this vitamin B12 is connected to intrinsic factor. So this intrinsic factor will bind to cobalamin. So now if we develop antibodies that they prevent from binding of intrinsic factor to cobalamin receptor, so we cannot absorb vitamin B12. Got it? So, as a collectively, they are called pernicious anemia. The second cause or the subtype of malabsorption is gastric atrophy due to autoimmune disease, due to diseases related to the stomach. Okay, and due to gastrectomy. Okay, during surgery, when we remove a part of stomach or all stomach, so we cannot absorb vitamin B12. Okay, or during ileal section. Okay, when we remove a part of ileum or all ileum due to cancer, due to any disease, so we cannot absorb vitamin B12. Got it? Plus, we have a type which is called food-bound B12 malabsorption. It means we cannot release vitamin B12 from food, and this is due to lack of pepsinogen. Got it? Plus, another subtype of malabsorption is intestinal disease. For example, in intestinal diseases, inflammatory bowel syndrome, specifically Crohn disease. In Crohn disease, we have inflammation in different parts of intestine, small intestine, large intestine, and so on. Okay, so we cannot absorb enough of vitamin B12. Got it? Here is a type of worm which is called fish top worm. This fish top worm competes for vitamin B12 absorption. It uses vitamin B12 for its own growth. Okay, so if a patient have fish top worm, okay, so this patient will not be able to absorb enough vitamin B12. Okay, plus chronic pancreatitis. Okay, you know that for absorption of vitamin B12 from previous lecture, we need trypsin enzyme from pancreas. So in chronic pancreatitis, patient will have less trypsin. Okay, and this trypsin is important for absorption of vitamin B12. So when we don't have enough trypsin, we cannot absorb vitamin B12. Got it? Sometimes requirement requirement increases. Okay, for example, during pregnancy, during lactation, during hyperthyroidism and hyperthyroidism. Okay, cell growth increases. That's why we need a lot of vitamin B12. And some uh, diseases that the causes increasement of cell production, for example in cancer. Got it? Plus, there are some drugs that they prevent from absorption of vitamin B12. The most common drug is metformin, which is used in type 2 diabetes mellitus, the first line drug for type 2 diabetes mellitus. Plus, long-term usage of PPI, for example, omeprazole, esomeprazole, lansoprazole, and so on. They prevent from secretion of HCl, and we need HCl or hydrochloric acid for absorption. Plus, these are, for example, H2 blockers, for example, famotidine, nazatidine, ranitidine. Okay, plus nitrous oxide. This is also called laughing gas. Okay, and it's also used for sometimes for anesthesia, and its long-term usage causes deactivation of vitamin B12. Got it? Plus, there are some causes related to genetic. It means mutation transcobalamin 2. We need transcobalamin 2 protein for transportation of vitamin B12. Cobalamin, we need cobalamin for absorption of vitamin B12 in the ileum. Okay, and this also called sometimes Grace-Beck syndrome. Got it? It's easy for vitamin B9. The most common cause is increased requirement or less intake. Okay, so less intake, alcoholism, increased requirement. For example, in pregnancy, and for example, in pregnancy during lactation and so on. Okay, plus malabsorption, plus some drugs. We discussed about methotrexate. Methotrexate is a drug which blocks dihydrofolate reductase enzyme, and we need dihydrofolate reductase enzyme to convert dihydrofolate to tetrahydrofolate to 510 methyl tetrahydrofolate in different forms of vitamin B9, plus trimetoprine, plus some anti-epileptic drugs and anti-cancer drugs. Okay, now how we can diagnose vitamin B9 or vitamin B12 deficiency anemia and its other complications. Okay, for best diagnosis, first of all, we take history. So patient will tell you the sign and symptoms that we discussed about them, and you will find some sign and symptoms in patient. Okay, then you will give CBC, and in CBC test you will find most of the time high MCV, main corpuscular volume. It means the size of RBC increases, and this is due to due to arrest of RBC in S phase, or due to less production, or due to less maturation of a cell or DNA that we discussed. Okay, but sometimes keep it in your mind. Sometimes you will not find high MCV, and this because in some diseases like iron deficiency anemia, like thalassemia, there is microcytic anemia, there is less MCV, so you will not find high MCV. Okay, plus in CBC you will find less hemoglobin level. Okay, hemoglobin decreases, RBC decreases, hematocrit level decreases. Okay, MCH most of the time it will be high or normal. Okay, because the production of hemoglobin is normal. MCH is most of the time normal, and or DW. Okay, it means you will find different size of RBC. Some of them will be small, some of them will be large, and we discussed about them in iron deficiency anemia also. Okay, plus sometimes you will find low WBC and low platelet levels, and most of the time it will be normal. Okay, most important, blood smear. In blood smear, if you find only one neutrophil that is hypersegmented, okay, and it consists hypersegmented nucleus, you can diagnose a patient with iron deficiency, or you can diagnose the patient with vitamin B9 and vitamin B12 deficiency anemia. Plus you will find poikilocytosis. It means different shapes of RBCs. Plus you will find anisocytosis. It means different sizes of RBCs. Okay, plus you will find sometimes macrocytic macrovalocytes. Got it? And in bone marrow you will find bone marrow hypercellular bone marrow. Okay, because there is a lot of production of cells. Bone marrow tries to produce a lot of cells, so you will find hyperproliferation bone marrow in biopsy. Got it? Now very important to diagnose vitamin B9 and vitamin B12. You can check vitamin B9 and vitamin B12 level in blood or serum vitamin B9 and B12. Okay, and when you find less vitamin B9, so this anemia is due to less vitamin B9, and if you find less vitamin B12, so this anemia is due to less vitamin B12. Okay, so now previously, to find the cause of vitamin B12 deficiency anemia, that this vitamin B12 deficiency is due to stomach disease, due to ileal disease, due to malabsorption, due to less intake, there was a test which was called Schelling test. But today's Schelling test is not prepared. Instead of this, we have more tests, and these tests are easy, plus they have less side effects. Okay, so for example, to find the cause of vitamin B12 deficiency anemia, you will give, for example, for the patient serum gastrin, because due to less HCl, you will find a lot of gastrin, because less HCl gives negative feedback to G cells, and G cells will produce a lot of gastrin. Plus, you can find some things in endoscopy, for example, in gastric atrophy. Okay, plus in bladder, okay, in serum, you will find antibodies against intrinsic factor or against parietal cells. Got it? Plus, you can seek and search for the diet history of the patients from the drugs and some conditions like cancer. Got it? We discussed about serum, folate, and vitamin B12 in serum. Now, listen me carefully. This is homocysteine. Homocystinemia and methylmalonic acid. These two increases in vitamin B12 deficiency, because in vitamin B12 deficiency we cannot convert homocysteine to methionine, so it increases. Plus in vitamin B12 deficiency you cannot convert methylmalonyl CoA to succinyl CoA, so methylmalonic acid increases. And in vitamin B12 deficiency, you will find neurological symptoms, okay, pains, and so on. But in vitamin B9 deficiency anemia, you will not find high methylmalonic acid. This will increase, but you will not find methylmalonic acid plus neurological sign and symptoms. And this is so diagnostic, differential diagnostic point between vitamin B9 and vitamin B12 deficiency. Got it? Now we discussed all of them. You can differential diagnose megaloblastic anemia with some other types of anemia like iron deficiency anemia, aplastic anemia, myeloid plastic syndrome, in some conditions that these are not due to vitamin B9 and B12 deficiency. They are due to some drugs, they are due to some enzymes that they are important for synthesis of thymidine or thymine. Okay, so you can also differential diagnose vitamin B9 and vitamin B12 deficiency with these conditions. Got it? Now come here to the last and easiest part of the lecture, which is the treatment of vitamin B9 and vitamin B12. Now, here is one type of treatment which is related to current medical diagnostic book 2026. Okay, and one is related to last edition of Harrison Internal Medicine, or I think it's 22nd edition. Okay, now listen me carefully. In current, it says that specifically in US countries, they use injectable cyanocobalamin, okay, and you will give 1000 micrograms, okay, IM, okay, daily for 7 days. Then you will give weekly for 4 weeks, okay. In each week you will give 1000 microgram injection IM. Then you will give monthly for 6 months. Plus you will give folic acid 1 milligram per 1 milligram per day PRN, or as it's needed specifically for 3 to 4 months. Got it? Or sometime you can also use hydroxycobalamine, and this hydroxycobalamine is used in for example in UK, okay, in these countries, okay. Plus you can also use oral cobalamin, and you can give a 1000 microgram daily or 500 micrograms 2 times a day, okay. Plus you can treat causes of vitamin B12 deficiency. Got it? Now, a side effect of injectable cobalamin or cyanocobalamin is allergy, allergy, allergy plus hypokalemia, because when you give vitamin B9 and folic acid, so now this bone marrow tries to make new cells. It activates. Okay, so during making of new cells, it will enter a lot of potassium inside the cell, because potassium is very important inside the cell. So it can cause, in severe anemia, it can cause hypokalemia. So be careful and manage the hypokalemia. Got it? Okay. Plus, keep it in your mind. This point is very important. Keep it in your mind. Never and ever use folic acid alone without knowing vitamin B12 level in the blood, or the cause of megaloblastic anemia. Because if you give folic acid alone, okay, this folic acid corrects anemia, but it will mask neurological symptoms. Okay, and sometimes later you'll find neurological symptoms, and it's in developing, and you'll face with a lot of severe neurological uh, sign and symptoms. This is very important. Plus, hydroxycobalamine is also used in cyanide poisoning. Okay, study for cyanide poisoning. The difference be- between the difference between current internal medicine 2026 and 22nd edition of Harrison medicine in treatment is only in dosage. Okay, how? Recent internal medicine tells you that give hydroxycobalamin, okay, for example, 6 doses totally, okay, and give 1000 microgram dose, single dose, each 3 to 7 days later. Okay, and totally give 6 doses for the patient, and then follow up your patient by 1000 microgram dosage each 3 months. In each 3 months give 1000 microgram dosage. So there is difference between dosage. Got it? And also in folic acid, Harrison says that you can treat your patient with 5 to 15 milligrams of folic acid. Got it? So when you treat your patient, okay, reticulocyte count increases in 1 week, and CBC will be and CBC normals around 2 weeks. Okay, and here is a form of cobalamin, which is called methyl cobalamin, which is used uh, most of the time for neurological symptoms. Got it? So these were all about megaloblastic anemia, or vitamin B9 and vitamin B12 deficiency anemia. Have a good time till next lecture.